Hello, I'm Harriet Seeger from Radcliffe Cardiology, and today I'm excited to have with me Professor Richard Sutton, Emeritus Professor of Clinical Cardiology at the National Heart and Lung Institute at Imperial College, London. Welcome today, Professor.
Thank you. Thank you.
Lovely to have you with us. And just also to say, Professor Sutton is an expert on syncope and pacemakers and pioneered the tilt testing protocol in 1984. Which is an incredible achievement. I'd like to start by pedaling backwards a little bit, if I may, and ask what led you to actually enter the world of medicine to start with.
Well, thank you. I think my father has to be held responsible for this in two ways. First, as a surgeon, he introduced me to medicine and took me to the hospital at least every Christmas. And this I found attractive. And the second part of his game was that he thought that medicine was no career for a young man. So he tried to talk me out of it. And as young men do, I responded in the opposite direction.
Quite right. So did you say also have any other family members that were in medicine as well that sort of encouraged you?
Not really, but I had a godfather who was a really, I think, fine general practitioner in Norfolk.
Right.
And I used to go on rounds with him when I was going to be and became a medical student.
Oh, okay.
He was inspirational too.
Okay. And so what actually led you to sort of specialise in cardiology?
So cardiology came because of opportunity, really.
Mm-hmm.
I had lent towards medicine rather than surgery, even as a medical student. And then people told me, well, the likes of you will never be a cardiologist. You're just not good enough. And that also was inspirational. And I applied for a job at the National Heart Hospital, which was then in Westminster Street. It's now recently closed again. And I didn't get the job, but one of the interviewing team, physician, cardiologist, Aubrey Leatham, called me a couple of days later and said, would you like a job in research in pacemakers?
Mm-hmm.
I said, well, that sounds very interesting. And it was a weekend, Friday afternoon, and I was on duty and I didn't have much work to do. So I read the literature on pacing, because in 1967 you could do that in a weekend of good attention. And I made a list of the things I wanted to study. And I went on Monday for the interview. I didn't realize that I was the only interviewee. But I had my list of things to study, and that quite impressed the three-man committee. And I got the job. Probably I got it anyway.
Oh, how funny.
But that started me in cardiology and started me in pacing.
Oh, okay. So you immediately went into pacing and then into syncope as well?
Well, yes, syncope, because the patients who were getting pacemakers in 1967 were almost all syncopal.
Okay.
And but no, not syncope in the general widespread term that we think of it today. Was specifically the syncope of atrioventricular block.
Oh, I understand. And so how did the tilt testing come about?
Well, that was quite a lot later.
Okay.
I continued my interest in pacing. But when I got a consultant post in 1976, so 9 years later, things didn't happen quickly in those days.
Right.
I was at Westminster Hospital, which had one other cardiologist who was frankly not very active. I mean, he was getting near retirement.
Okay.
And the Westminster had cardiac surgery, it had a cardiac catheter laboratory, and practically nothing else. So I thought to myself, well, I've got no staff, just me. What can I do?
Mm-hmm.
So the obvious thing to do was pacing, because I could do all of that myself.
Okay.
And so I started with that, and I implanted 50 pacemakers in the first year, much to the disquiet of administration, who didn't really want to pay that bill.
Oh.
But this was a successful campaign, and later became Westminster's strength, or one of them. And I thought, well, I'm treating patients who have syncope, but I'm also treating others who have slow heart rates.
Mm-hmm.
But there are masses of patients with syncope that I'm not doing anything for, and maybe pacing could work for them. So I started to try to extend the horizons.
Mm-hmm.
And this came from good cooperation with David McBrien, who was a physician in Worthing, who found out about me, and I found out about him, and he used to send me a lot of patients. And there were all kinds of syncopal patients that he said, I don't know what to do with these people, but they need help.
Mm-hmm.
And I put pacemakers in some of them, and they did rather well. But I always wanted a good reason for putting in the pacemaker. And this is the threshold of the tilt test.
Okay.
Because patients were syncopal, and we didn't really necessarily understand why, what was the mechanism. So how to treat it blindly to put in a pacemaker was not my style.
Mm-hmm.
So we started on a research project which was trying to find out about being upright and the hormonal and nervous connections to various parts of the body that might influence tolerance of being upright. And now Professor Roseanne Kenny was the research fellow. She's now in the head of geriatric cardiology in Dublin. She was the research fellow. And we started with patients with carotid sinus syndrome, which is the old people's problem, and they do have syncope. And she came to me after some weeks and said, I can't do this project because all the patients pass out before I get to the point of measurement. So I said, now this is interesting.
Mm-hmm.
And so I said, well, instead of bothering too much about the measurements, try another group of patients whom we've investigated for syncope but cannot find a cause, and tilt them, because the protocol was tilting.
Okay.
So she did this, and she came back much happier the next week. She said, they're all fainting too. Okay, now you've got to get an age-matched group of similar number by going around the hospital recruiting them. She's a very charming person, recruited them easily.
Okay.
And they one of them fainted only.
Okay.
So we thought, now we've got a test to expose the problems of these patients we couldn't diagnose.
Oh, fantastic.
So we rather gave up carotid sinus syndrome and concentrated on those that we had investigated and found no cause.
Okay.
But on the tilt table, they fainted.
Right.
So we wrote this up, and we had some inkling that they were doing something similar at the Cleveland Clinic,
Right.
and possibly also at the Mayo Clinic.
Okay.
We've got to get this into print quickly. In those days, the Lancet used to review everything in-house and make a decision in 2 weeks. So we wrote this paper about these three groups of people and sent it to the Lancet. And they responded within 2 weeks, no.
Oh.
I was disappointed.
Mm-hmm.
Being arrogant and bombastic, I wrote them a letter saying, if you reject this paper, you will evermore regret it.
Right.
And not the way to do things today.
No.
And I suggested that you have outside reviewers and gave them a list. Well, also not much done today.
No.
And I don't know what they did, but they agreed to publish it. So in 1986, we've been working on this for 2 years.
Mm-hmm.
We published this paper on the Lancet, and that was the beginning of tilt testing.
Ah, and the rest, they say, is history. So that presumably that's been one of your proudest moments in your work, or have there been any other sort of career highlights as well?
Well, I mean, I think the continuous recurring highlight is people like Professor Roseanne Kenny,
Right.
who were great research fellows and went on to greater things. So that's given me more pleasure looking back over my career
Oh.
than anything.
Oh, how very modest. So stepping back into the present, can you tell us a little bit more about research that you're doing regarding the tilt test as a risk stratification tool as opposed to a diagnostic one?
Yeah, well, what we have done recently is to try to pick the older patient with reflex or vasovagal syncope who would benefit from pacing. And this is a kind of career theme, but gradually it's got more and more focused.
Okay.
We started in the 90s with pacing people, older age group who were fainting, and we had rather good results. We were comparing with no treatment.
Okay.
And this was not really acceptable. And two studies followed, one of which I was involved in, the other one was in North America, that compared patients all with pacemakers, half switched on, half not.
Right.
Switched off. So there wasn't a difference in these two groups. So I and some other more important and active people said, there's got to be something in this, but we must be selecting the wrong patients.
Mm-hmm.
We've got to improve selection. So we started a study called Issue 2, which took patients of that kind of presentation, implanted a loop recorder for the electrocardiogram in all of them, and waited for a recurrent spontaneous attack.
Mm-hmm.
When we got it, we could see that a lot of them were intensely bradycardiac or had asystole.
Right.
This was only a registry, so we said to the caring physician, we have found this. You may do with the patient, of course, whatever you wish.
Right.
Interestingly, half of them said, oh, this patient needs a pacemaker and implanted. And the other half said, oh, we're not interested in this, or whatever they did say, we don't know, but they didn't do it.
Oh, okay.
We had two comparative groups who were sourced very similarly. It was not a randomized controlled trial, but we could say that the paced patients, who were very similar to the unpaced patients, did very well.
Okay.
So now we've got the basis for a randomized controlled trial.
Mm-hmm.
Raised support from Medtronic.
Right.
Also supported Issue 2, and this new trial we called Issue 3.
Okay.
And we recruited the patients in the same way. They seemed to have reflex syncope. They had an implanted loop recorder, so we started with more than 500.
Okay.
And we waited for recurrent spontaneous attacks. In a year, we got something like 89 patients who had recurrent attacks.
Okay.
And we said now they must move on to stage 2, which was implant a pacemaker in all of them,
Right.
randomize them to being switched on or switched off.
Mm-hmm.
And some of them dropped out at that stage because they said, okay, we know what the problem is, we should have a pacemaker and not be randomized. Well, their doctors said this.
Okay.
So we got 79 or so patients who were randomized. It went 2 years, and those whose pacemakers were on had recurrent syncope at 25% in 2 years.
Mm-hmm.
Those whose pacemakers were off had recurrent syncope in 57%. So this was statistically significant difference.
Right.
And the first time that a controlled trial had shown that pacing could help some of these people.
Okay.
And later we had followed the registry patients who had refused a pacemaker or refused randomization. So we had larger numbers. Okay. And we then see that, and I forgot to mention, that tilt testing was not part of the protocol, but most investigators did it. So we had the data. And we could see that if you had a negative tilt test and asystole on your loop recorder in a spontaneous attack, right, you did extremely well, 5% recurrence in 2 years.
Okay.
And if you had a positive tilt test and asystole on your loop recorder, you did as badly as if you didn't have a pacemaker or it was switched off.
Right.
So that said, we've got to rethink tilt testing,
Okay.
because although it still is diagnostic, when it reproduces an attack that a patient has previously experienced.
Right, I understand.
What is more powerful is that it's a risk stratification tool. You can say to the patient who has a negative tilt test and a positive loop recorder, we'll give you a pacemaker and we expect you to do well. If they have a positive tilt test, we would have to say, you may do well, but there may be limitations and you may have recurrences.
Okay. So, how long into the future do you see this taking shape and affecting current practice?
Well, I think that this is a bit of a new concept, so it's going to take some time.
Okay.
But to back this up, an Italian group has done a study from 10 centres in Italy.
Oh, okay.
Took patients, as it were, walking in through the door. They did carotid sinus massage to exclude carotid sinus syndrome.
Okay.
They did a tilt test. If it was positive, they put in a pacemaker, the patient having been syncopal in the first place.
Right.
Tilt. Or negative, they put in a loop recorder. And that allowed them to show exactly the same as the issue 3 study had shown.
Okay.
And now they have, the latest paper isn't out yet, but it's accepted for publication in Europace, that over 2 years, their kind of normal patients behave in the same way. Loop recorder positive, tilt test negative, very good result. Loop recorder positive, tilt test positive, not such a good result.
Right, okay. So that could be, a significant advance, isn't it, in the next few years, which is exciting.
I think it's really focused where I wanted to focus on who's going to do best.
Okay, fantastic. One final question, and this is really advice for up-and-coming cardiologists. Do you have any advice from your career, any sort of valuable lessons we could talk about to share with people watching this video?
Well, I think the first thing is, if you're inclined toward cardiology, it's still a wonderful career and full of opportunities, and it's changed hugely during my practicing years. It's going to change equally hugely in the coming 40 or so.
Okay.
There are lots of opportunities to do more for patients. And the second thing is, having chosen cardiology, you must think about doing a research project that ends in a MD or preferably a PhD.
Okay.
So this way you will understand research better. Even if you don't do it in the future, you can understand what other people are writing about much better, which ones to take most seriously and which ones to take less seriously.
Okay, well, that's a very important point. Well, thank you so much for joining us today, Professor Sutton. It's been most insightful, and I'm sure our audience will benefit greatly from hearing your career path and advice for them too. So thank you so much. And just also to tell our viewers that we'll put some more information about you under the video, which you'll find on our website, www.radcliffecardiology.com. So thanks so much for joining us today, and
Thank you.
I hope you enjoy the rainy weather in Monaco.
Yes.